Heart sounds are the sounds which are heard during each cardiac cycle, and they are produced due to the vibrations in the wall of the heart due to abrupt acceleration, if there is acceleration of blood, or abrupt deceleration of the blood. Suddenly it is stopped, the blood moving is stopped. We have four types of heart sound which are named as S1, S2, S3 and S4. S1 and S2 are the main heart sounds which are heard physiologically. S3 can be heard sometimes physiologically, but if S4 is heard, it is always pathological. S1 occurs due to the closure of the mitral and tricuspid valves, AV valves. Okay, mitral valve is present between the left atrium and left ventricle, and tricuspid valve is present between the right atrium and right ventricle. So here this is the tricuspid valve, okay, and this is the mitral valve. When these valves close, there is production of first heart sound. So this sound occurs just before the ventricular systole. When the heart starts contracting, as it starts contracting the ventricle, the pressure in the ventricle rises. This leads to shutting down of this valve. Okay, so there is a pressure rise which causes the shutting down of the valve, leading to first heart sound. So it is heard before isovolumetric ventricular contraction, just before the ventricular systole. Then S2, S3 and S4 are heard during ventricular diastole. S2 is due to closure of the semilunar valves which are present between the ventricles and the blood vessels. So there is a valve between the right ventricle and the pulmonary artery. This blue one is the pulmonary artery. So this valve is the pulmonary valve. And there is a valve between the left ventricle and the aorta, this valve, and this valve is the aortic valve. The shape of the valves is semilunar, so they are known as semilunar valves. S2 is due to closure of these valves. And when do these valves close? As the ventricles start relaxing, there is fall in the pressure of the ventricles below that of the atriums. Okay, it is important, the pressure gradient you have to note. Okay, so when the ventricle pressure starts increasing, there is closure of the tricuspid and the mitral valve. This occurs because there should not be any backflow of blood from the ventricles to the atrium. Okay, so to prevent the backflow of blood, there is closure of the tricuspid and the mitral valve. S2 occurs as the ventricles start relaxing, so that the backflow of blood from the pulmonary vessels and aorta should not occur to the ventricles. Okay, so there is closure of these semilunar valves as the ventricles start relaxing just after the protodiastole, that is S2. S3 and S4 are low pitched sounds and they occur during ventricular filling by the movement of the blood. So first rapid filling, when the ventricle is relaxing, there is protodiastole causing S2. There is isovolumetric relaxation where there is no filling of the ventricles. Then there is rapid filling. Basically all the blood which has been collected in the atrium, as these valves open. Okay, so this is opening. Opening of the valves doesn't produce sound. It is only the closure of the valves which is producing the sound. Only in abnormal conditions do we hear some sounds due to opening of the valve, like opening a snap. Okay, physiologically, opening of the valves does not produce any sound. Fine. So at the end of the isovolumetric relaxation, there is opening of these AV valves, and this causes sudden gushing of the blood which is present in the right atrium and left atrium into the ventricles. So this sudden acceleration of the movement causes S3, which is a low pitched sound. Then S4 occurs during the atrial contraction, that is the second rapid filling. So atria contracts powerfully, causing the rest of the blood which is present in the atria to move into the ventricles. So this causes the fourth heart sound. Again, physiologically it is not heard, only in some pathological conditions it may be heard. S3 sometimes can be heard physiologically, and that is in children and young athletes, basically athletes less than 30 years of age. So what we have seen that S1 and S2 are always heard. S1 is just before the start of the ventricular systole. So between S1 and S2 we have ventricular systole. Time duration is 0.3 seconds. And S2 is just after the protodiastole. Ventricle has just started relaxing. So between S2 and S1 there is ventricular diastole. Okay, and then we are having the next cycle of the heart starting. So between S1 S2 there is ventricular systole. Between S2 and S1 we have ventricular diastole. And if we have to mark S3 and S4 in this graphical version, where should I mark? Just after S2 there is isovolumetric relaxation and then rapid filling. So here there will be S3. Okay, I am drawing small because it is low pitched. Okay, so here it will be S3. And then there is a slow filling, and then there is atrial contraction. So here somewhere near S1 it is S4. Okay, S4. So S2, S3, S4 are diastolic heart sounds. Now if heart rate increases, how these sounds will appear? See, normally the sounds are heard as lub-dub, 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 like this. But when heart rate increases, this diastole duration is decreasing much more. Yes, systole is also decreasing, diastole decreases much more. So we will start hearing them much closer. So the gap will be lesser. So something like this you will hear, lub-dub, 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 lub-dub. So you will not be able to appreciate that which one is S1, which one is S2. That is why while auscultation, we need to know auscultatory areas and how to auscultate the heart sounds to differentiate between first and second heart sound. So we have different auscultatory areas. Here it is shown a thoracic wall with different areas marked. Okay, so this is right side and this is left side. This area is the pulmonary area. Pulmonary area is basically second intercostal space, left side second intercostal space, just next to the sternum, just next to the sternum. Then this A is the aortic area, aortic area. Okay, aortic area is right side second intercostal space, just next to the sternum. Then in the fifth intercostal space, we have the mitral and tricuspid area. So this D is the mitral area, that is fifth intercostal space, left side, mid-clavicular line. So we are auscultating for mitral valve closure in the apex of the heart. Okay, left fifth intercostal space, mid-clavicular line, and here C is the tricuspid area. Tricuspid area is again left side, okay, left side fifth intercostal space, just next to the sternum, okay, parasternal, just next to the sternum. So these sounds which we are seeing S1, S2, they are best heard in these areas. And why we have 4 areas? Because we have 4 valves, okay. So tricuspid closure will be best heard in area C, then mitral valve will be best heard in area D, and we can say that in CD area S1 is louder. Okay, and in AB area, which are for the closure of the pulmonary valve and aortic valve, S2 is louder. Okay, so that is one thing. Second thing is that while auscultating, we should always palpate the carotid artery. Always palpate the carotid artery. Okay, as we feel the pulse in the carotid artery and we hear the sound, we match that which sound is matching with the pulse of the carotid artery. So that is S1. S1 always matches with the pulse of the carotid artery. So this helps us in differentiating which sound is S1 and which sound is S2, especially when the heart rate is more. So always remember, while auscultating, palpate the carotid artery. S1 coincides with the pulse of the carotid artery. Now coming to variations in these heart sounds. We will talk about when these heart sounds become soft or loud. We will talk about a splitting of the second heart sound, and we will also talk about the pathological conditions in which S3 and S4 are heard. So whether the sounds will be soft or loud depends upon 2 or 3 things. One is the state of the valve leaflets and the pressure difference between the chambers and how fast this pressure difference is developing. Right. For example, S1. S1 we said is due to closure of the mitral and the tricuspid valve. So, if these valves are calcified, they will not be able to close properly. There will be hardly any movement of the valve. Okay. So, in that case, we will get soft S1. Okay. Calcified valves. Calcified mitral and tricuspid valves, and this happens in case of mitral stenosis, tricuspid stenosis. Okay, then it will also be soft in case of mitral regurgitation. Why? Mitral regurgitation occurs when there is no closure of these valves. Okay, when mitral valves don't close properly, then we get mitral regurgitation, tricuspid regurgitation. So they are not closing properly. So both will lead to soft S1. However, loud S1 occurs in mitral stenosis and tricuspid stenosis. See, this is little bit difficult to understand. Try to understand here that when the valves are calcified, which happens late in case of mitral stenosis and tricuspid stenosis, then we get soft S1. But during early stages of mitral stenosis and tricuspid stenosis, we get loud S1. Okay, so because the valves are sclerosed, and then we get loud S1. Then loud S1 is also heard in case of tachycardia, increase in heart rate. Why? Because in tachycardia, what happens that the rate of rise of the ventricular pressure, as the ventricles start contracting, rate of rise of ventricular pressure is too much. Okay, so if this is left atrium and this is left ventricle, these are the valves. Suddenly, the pressure starts rising, and this will cause the sudden closure. The pressure difference is such that it will push the closure of the valve, and this sudden closure will cause loud S1. You can realize that if you are closing a door, if you close with very high force, the sound will be very high, right? So there will be loud sound. Similarly here, when rate of rise of left ventricular pressure is more, then we get loud S1. Okay, so tachycardia, there will be loud S1. And with the same logic, if there is increase in PR interval, then there will be soft S1. Fine. Moving on to soft and loud S2. Loud S2 occurs in case of pulmonary hypertension and systemic hypertension. Why? So here this is the right ventricle, say suppose. Okay. Now here this is the vessel which is going. If the pressure in this pulmonary valve is much more, pressure here is much more, then again you see that it will just shut the semilunar valve. Okay, so same force is much more, so we get loud S2 in pulmonary hypertension and systemic hypertension. Same thing is happening on the left side. The pressure in the aorta is much more, so it is just shutting the valve with much force. Soft S2 occurs in case of atrial stenosis. Okay, because in atrial stenosis the aortic valves are immobile. So that was about the soft or loud sounds. Simple, you have to remember that what is the state of the valve leaflets and what is the pressure difference between the chambers. More the pressure difference, it will create more louder sounds. Okay. Moving on to the next concept of splitting of the second heart sound. Okay, so we were talking about S1 and S2, but actually this S2 component consists of two components. S1 also consists of two components. There is closure of the mitral valve, there is closure of the tricuspid valve, but they are heard as one sound, and that is why it is known as S1. But S2, the sounds A2, P2, that is the aortic component, closure of the aortic valve and closure of the pulmonary valve, there is a splitting during inspiration. So what happens? There is closure of A2, P2 valve together in case of expiration, but during inspiration, this component separates. So how we see is, say suppose this is S1, okay, and during inspiration there is this splitting. So first we see A2 component, okay, and then after some gap we get the P2 component. So there is splitting of this heart sounds. This is much closer, but we get S1, A2, P2 component during inspiration. And why is this happening? See, during inspiration there is negative intrathoracic pressure. Okay, there is negative intrathoracic pressure. This increases the venous return to the right side of the heart. Okay, increased venous return to the right side of the heart, and this leads to increased blood in the right side. So because of increased blood, now right ventricle will contract for a longer duration because it has to push blood to the pulmonary vessels for a longer duration. There is increased volume in the right ventricle. Okay, so right ventricle contracts for a longer duration, but aortic valve by then has closed. Okay, so it is because of the delayed closure of the pulmonary valve, because of the volume increase in the right ventricle during inspiration. But one more thing happens, right? What happens that because of this decreased intrathoracic pressure on the left side, there is decrease in venous return. Please try to understand this because this will help you understand that what happens in atrial septal defect. So on the right side, there is increase in venous return, but on the left side, there is decrease in the return to the left side of the heart. Why? Because in the lungs, pulmonary vessels are there, Because of decrease in the intrathoracic pressure, these pulmonary vessels actually diameter increases. Okay, so imagine there is negative intrathoracic pressure and these are the pulmonary vessels. Now surrounding pressure becomes negative, so there will be pull on the walls of this pulmonary vessel, so the diameter is going to increase, so they are going to accommodate more blood during inspiration, thus the return of the blood to the left side is going to decrease. Okay, so decreased blood to the left side of the heart, thus the blood in the left ventricle is lesser, so obviously the flow from the ventricle to the aorta will be lesser and aortic valve will close faster. Okay, aortic valve will close faster, right? So both side differences happening. Generally they give this much in book, but then we don't understand what is happening in atrial septal defect. Okay, so decrease intrathoracic pressure leads to increased venous return to right side, causing delayed closure of the pulmonary valve, while on the left side there is decrease in return. This leads to early closure of the aortic valve. So that is why in S2 we say A2P2 component during inspiration, but during expiration they come together and it is heard as one sound. Fine. So that is physiological splitting of the second heart sound, which is heard during inspiration. And can you tell in which auscultatory area it will be heard better? It will be heard better in the second intercostal spaces, isn't it? Second intercostal spaces just next to the sternum, right side and left side, where aortic and pulmonary areas are respectively. Now moving on to variations of this splitting in pathological conditions. So we have different variations. First one is wide split. Wide split. Okay. So this is showing the normal condition. Wide split is when the time duration between the A2 and P2 has increased, so that now it will be heard during expiration also. So let me draw. So during expiration, it is like this. This is the A2 component. This is S1. Okay. This is the A2 component during expiration, and this is the P2 component. Okay, this is the P2 component, and this variation will increase during inspiration. So there will be A2 component like this, but this P2 will be further delayed because of the increase in the venous return to the right side. Here I am making too much gap, it is not that much, but just for graphical representation. Okay, so what we are seeing that in expiration there is a split heard, and also in inspiration there is increase in this split. So this is known as wide splitting, and because it is changing in expiration and expiration. Wide, yes, it is heard in both expiration and inspiration, but in inspiration it is increasing, so it is known as variable wide split. Generally we call it wide split only, but it is variable, it is increasing during inspiration, right? And when will that occur? It can occur if A2 is early or P2 is late. Understanding? So this is the normal duration. This is how normally it is occurring, A2, P2. If A2 becomes early or P2 becomes late, then this split is going to be wider, isn't it? So what are the causes? When can it occur? See, P2 late. Why is P2 late physiologically? Because of increased right ventricular volume. So anything which further increases right ventricular volume, P2 will become late. What are the causes? First is right bundle branch block. Right bundle branch block. That is because right side is excited later, ventricle contracts little later, so P2 closes little later. So that is one. Second is pulmonary stenosis. Pulmonary stenosis, what is going to happen? That the blood flow which is happening from the ventricle, it will flow slowly into the pulmonary valve. Okay, because there is so much resistance to movement. Pulmonary stenosis is when the valves are not opening properly. Okay, pulmonary valves are not opening properly, so the orifice is smaller. So blood flow from the ventricle, right ventricle, this side, it will be very much slow into the pulmonary artery. So that's why the right ventricle will contract little longer. So that is the cause of late P2. A2 early, why it will occur? A2 early means that aortic valve is closing early. That means left ventricle is very fast. It is emptying. Okay. So this can occur in two cases, that is mitral regurgitation and also in ventricular septal defect. Why? In mitral regurgitation, when the left ventricle is contracting, blood is going into the aorta, yes, but it is also going back into the left atrium. Okay, so two side pathways is open, so that is why left ventricle gets empty of the blood. It's not totally empty, but the systole ends faster because the blood is going into two chambers, right? One in the aorta, one in the left atrium. So that is one. Second, VSG also similar thing happens, that the blood goes back into the right ventricle. Okay, so there is right ventricular overload also, and there is much faster emptying of the left side. Okay, so A2 early occurs in mitral regurgitation and ventricular septal defect. Understanding. So again, wide splitting of this S2 can occur when A2 is early or P2 is late, and you can think that when it will occur. So even if you don't remember, just think how it is working. Okay, so this is variable wide split. Coming to fixed wide split. Fixed wide split. Okay, fixed wide split means that yes, there is A2 component and P2 component both in inspiration and expiration, but the distance between them, it is same. It is not increasing during inspiration. Now, why it can occur? We know the physiological basis of that, why there is a splitting, because of increase in right ventricular volume during the inspiration and decrease in left ventricular volume during inspiration. So fixed wide split is that during inspiration and expiration, it is not happening. Okay, the volume in the right ventricle is same during expiration and expiration. Now, why it can occur? See, in atrial septal defect, this occurs. Okay, we will see how this is occurring. Now, in atrial septal defect, in expiration, what happens? We will see two ways, that what is happening to the venous return and what is happening to the blood which is coming from the left side. In atrial septal defect, what happens, that the blood from the left atrium enters into the right atrium. So there are two ways in which blood is entering into the ventricle. One, blood is coming from the superior vena cava and blood is coming from the left side of the heart. Okay, so two ways are there through which blood is entering to the right side of the heart, and ultimately from right atrium it will move into the right ventricle. Now, during expiration, what happens? We are talking during expiration. See, we will call it 1 and here it is 2. So during expiration 1, that is from the superior vena cava, venous return is going to decrease. But from that of the 2, from the left side, from the left atrium which is entering to the right atrium, return is going to increase. How? See, I told you that during inspiration, the blood flowing into the left side from the pulmonary vessels is lesser because there is increase in the pulmonary vessel capacitance. They have dilated. Okay, they have distended. But during expiration, that is not going on. During expiration, more blood enters into the left atrium. Okay, so during inspiration, more blood enters into the right atrium from the superior vena cava. During expiration, more blood enters into the left atrium from the pulmonary vessels. Okay, so during expiration, venous return from the superior vena cava is decreasing to the right side. But during expiration, because more blood has come to the left atrium, it is entering into the right side. Okay, so this is occurring during expiration. Let us see what happens in inspiration. In inspiration, during inspiration, what happens, that superior vena cava blood, the first part which is there, venous return is increasing, but from the left side, the blood which is coming to the right side, it is going to decrease because now less blood is coming to the left atrium from the pulmonary vessels. Okay, so yes, this is increase. Okay, superior vena cava blood venous return is increasing, from the left side it is decreasing. So you see how it is balanced. Okay, so there is no change in the ventricular volume in inspiration or expiration. So what we are getting is fixed split. Okay, fixed wide split we get. There is no change in the volume which is entering to the right ventricle. However, the volume has increased because it is coming from two pathways. Hence, right ventricle contracts for longer duration, causing a wide split, right? And since the volume is fixed during inspiration and expiration, it is a fixed wide split. Okay, so that occurs in atrial septal defect. Okay. Moving on to next part, that is paradoxical split. Paradoxical split. So we have seen normal splitting of heart sound. We have seen Fixed wide split, we have seen variable wide split. Now, we will talk about paradoxical split, or also known as reversed splitting of the heart sound. Reversed splitting. What is that? As the name suggests, paradoxical splitting. That means splitting will be heard during expiration and not during inspiration. Okay. So normally we have seen that A2 is early, P2 is late. Now if opposite happens, okay, so let me draw here. If this is S1 and here this is A2 and here this is P2. Okay, if A2 moves late and P2 becomes early, then we will see reversed splitting. Okay, P2 is early, A2 is late. So we will see reversed splitting, also known as paradoxical splitting, right? And why it is heard in expiration? Because see, in inspiration what is happening, let me draw. Suppose P2 becomes, it is reversed. Suppose P2 becomes early and A2 becomes late. Suppose it is happening like that. During inspiration, what will happen? Because of the natural delay of P2 which occurs during inspiration, because of increased right ventricular overload, P2 will move closer to A2. Okay, so it will be something like this. So it has become 1 again, right? Because of the natural, because of the normal physiological phenomena. Okay, so P2 is moving closer to A2 during inspiration. So paradoxical split is not heard during inspiration, it is heard during expiration. Okay, so what can be the causes? A2 late, when it can occur? A2 late, that can occur in left bundle branch block, left bundle branch block, because excitation of the left ventricle is delayed, so there will be delayed contraction of the left ventricle. Then it can occur in atrial stenosis, right? P2 late we saw it is occurring in pulmonary stenosis. Here A2 late will occur in aortic stenosis, because again the flow from the left ventricle to the aorta will be delayed, right? Then there can be HOCM, hypertrophic obstructive cardiomyopathy, again similar cause, because the flow will be delayed. P2 early can occur in pulmonary hypertension. Okay, but remember, pulmonary hypertension, it can cause reverse split, it can cause narrow split also. Okay, so whatever was there, little bit P2 has become early. So suppose this is the A2, normally this was P2. Okay, so this P2 when moves little bit before, then it is narrow split. So P2 moves little bit closer, narrowing of the split occurs. Or if it moves a little bit much more closer, then there will be no split. Understanding? So how much is the pressure in the pulmonary vessels and what is the cause of the pulmonary hypertension? There are many factors which determine that how in pulmonary hypertension the splitting will be heard, whether it will be paradoxical split. If P2 is too much early, that it occurs before the A2, then it will be paradoxical split. If it is not that much, if it comes closer to A2 only, then it will be narrow split. If it just comes with the A2, then it will be no split. Okay, so pulmonary hypertension can lead to all these. They can be no split, paradoxical split, or narrow split. So that was about the splitting of the second heart sound. Now moving on to the last part, that is S3 and S4. As I told you before that S3 is low pitched and S4 is also low pitched sound. S3 occurs during the first rapid filling of the ventricles, that is the sudden gushing of blood from the atrium to the ventricles as these AV valves open. Okay, so whatever blood is there in the atrium, it suddenly gushes into the left ventricle. Normally it is seen in children and young athletes. And when it will increase? It will increase in case of mitral regurgitation and tricuspid regurgitation. Why? Because there is so much blood accumulation in the atrium. Regurgitation means when the ventricles are contracting, then blood moves back into these atrium. Okay, so already venous return is coming and blood has come back to the atrium from the ventricles as well. So there is so much blood in the atrium. So as the valves open, this gushing of blood, this movement of blood increases to the atrium. Okay, it can be either mitral regurgitation or tricuspid regurgitation. Then constructive pericarditis. Constructive pericarditis is basically there is a constriction in the pericardium. Pericardium is a layer surrounding the heart and it is constricting the ventricle. So what happens, as the blood is gushing from the atrium to the ventricle, there is sudden stoppage of that movement because of the constrictive pericarditis. It is stopping the movement. And before, if you remember, I told you that the sounds are produced due to sudden acceleration and deceleration. In MR and TR, there is more acceleration because of the more blood. In constrictive pericarditis, it is opposite. It is sudden deceleration. Whatever blood is coming, something is stopping it. Okay, so that is constrictive pericarditis. And in fact, in constrictive pericarditis, this S3 is known as pericardial knock. Pericardial knock. Okay. Then other causes are volume overload in ventricles, okay, as in case of systolic heart failure, dilated cardiomyopathy. So there is already lot of volume in the left ventricles and right ventricles, whatever ventricle we are talking. So volume overload in ventricles, as in case of systolic heart failure. Dilated cardiomyopathy also leads to systolic heart failure. The heart is not able to contract, okay, so that will cause S3. Next causes hyperdynamic circulation. Hyperdynamic circulation as occurs in anemia, thyrotoxicosis, vitamin B1 deficiency, beriberi. So in these cases, there is peripheral vasodilation and the heart contracts much more. Okay, so there is hyperdynamic circulation that also leads to S3. Then S4. S4 again is low pitched and it occurs during atrial contraction, that is the second rapid filling. So again there is sudden gushing. Normally it is not heard, but it is heard in case of hypertrophic ventricle. Hypertrophic ventricle, because there is like these ventricles, they become hypertrophic. Okay, so when they become hypertrophic, there is increase in the pressure in the ventricles. Increase in the pressure. So in S3 there is volume overload in the ventricles. Pressure is lesser because there is systolic heart failure. Here we are talking diastolic heart failure, that is which occurs with hypertrophic ventricles. Hypertrophic ventricles, the heart is not able to relax properly. There is decreased ventricular compliance of the ventricles. Okay, so now because of this there is increased pressure in the ventricles. It is not able to relax, so that is going to increase pressure. So atria has to contract more powerfully to overcome this increased pressure. Okay, only when atrial pressure becomes more than this ventricular pressure, then only the blood can enter from the atrium into the ventricles. Okay, so that powerful contraction of the atria causes a sudden gushing of blood into the ventricles, and that leads to fourth heart sound. Okay, and it is always pathological. It occurs in systemic hypertension, pulmonary stenosis, aortic stenosis. All these lead to hypertrophy of the heart. HOCM again, hypertrophic obstructive cardiomyopathy, which again leads to hypertrophy of the heart. Okay, so decreased compliance. Now this S4 is absent in atrial fibrillation. Absent in atrial fibrillation. Why? Atrial fibrillation, what is the problem? Atria are not contracting, right? It is just fibrillating. So if atria are not contracting, we will not get fourth heart sound. And when it becomes significant? It becomes significant when the sound was there before and suddenly there is development of the atrial fibrillation. So you can see that how the disease is progressing. Initially there was presence of fourth heart sound, but later on it has become absent. So that is a sign of development of atrial fibrillation. So that was about the heart sounds. We discussed what is the physiology of the heart sounds. We discussed that when these sounds will become loud or soft. Then we discussed about the splitting of the second heart sound, and we discussed about some causes of S3 and S4 heart sounds. Thanks for watching the video. If you liked it, do press the like button, share the video with your friends, and don't forget to subscribe to the channel Physiology Open. Thank you.